friends. I'm here to talk to you about an interstitial lung disease for which there's emerging evidence and management plans which are different to an extent from other interstitial lung diseases. And we have named this case as navigating the scleroderma lung conundrum. Let me come to the case proper. This is a 42-year-old female who presents with the 18-month history of progressive shortness of breath. The cough that accompanies the breathlessness is like most other ILDs, moderate, dry, non-productive cough without nocturnal awakening. She also has recent onset dysphagia, particularly to stop or to solid food. She reports heartburn, acid regurgitation, and often has bouts of cough during or just after taking food. Further questioning, direct questions, also reveal episodes of bluish discoloration of her fingers when exposed to cold temperature, like what you see on the photograph. The patient has no significant past medical history. She has no past addictions or pets. She has no family history of interstitial lung disease. And important for you to remember even these negative histories, which are important to take from your patients, not just of scleroderma, but of interstitial lung disease as a whole. Physical examination reveals skin tightening and fissuring at the angle of the mouth. The oral aperture, the opening of the mouth, was much lesser than what would be expected. There was similar tightening present on the palmar and the plantar surfaces. Telangiectasias were noted at the tips of the finger and also on the face, especially around the eyes. Chest auscultation revealed scattered crackles almost all over the chest, but mainly over the bilateral axillary, interscapular, and infrascapular areas. The lab investigations, the basic baseline tests were all generally normal. Serological evaluation, however, were positive for antinuclear antibody, for anti-SCL70 antibody or the anti-scleroderma 70 antibody, and the anti-centromere antibody. Remember this combination. This combination is important because it points towards scleroderma, but also points at a high risk of interstitial lung disease and of a poor prognosis overall. The lung function tests equally important. So FVC of 1.58 liters, which was 67% of predicted, a DLC of 42% of predicted, a 6-minute walk distance, which was good at 400 meters, but with significant desaturation. She desaturated from 96% to 87%. The CT features, the carry home messages from the CT, will be discussed by my radiology colleague. However, important to mention that the changes that you see on the photograph are predominantly basal and subpleural and are characterized by cystic air spaces. And important to see these cysts, this are classic of CTD ILD and especially of scleroderma ILD. These cystic air spaces have well-defined walls and they're arranged in layers in the subpleural and the posterior basal lung zones. The HRCT pattern here that you see is consistent with UIP and this loss of lower lobe lung volume that you see. The echocardiograph shows grade 1 diastolic dysfunction, which is indeed quite common, and the LV ejection fraction was preserved. The pulmonary artery systolic pressure was high at 64 millimeters of mercury. The MPAP was 46 millimeters of mercury, and there was a large TR jet, all of which indicated that she had significant pulmonary hypertension. Remember, scleroderma not just causes interstitial lung disease and hence pulmonary hypertension, it also causes primary affection of the pulmonary vasculature. It causes arteriopathy and hence pulmonary hypertension. So pulmonary hypertension in scleroderma is often much higher than from other causes of interstitial lung disease. So the diagnosis here was based on clinical features, the imaging findings, the serology, and all of them together point to a diagnosis of progressive systemic sclerosis along with interstitial lung disease, along with pulmonary hypertension. The treatment given to her initially was corticosteroids along with mycophenolate. The corticosteroid dose here is tapered rapidly. A maximum of 4 to 8 weeks is what you would give these people. You can actually cause a renal crisis giving steroids to patients with scleroderma. The mycophenolate was continued long term, as was antifibrotic nintedanib, which was initiated at a slightly later stage. So, points to remember from this case of scleroderma: the fact that this patient, this lady, had a rare serologic finding of dually positive antigens. You had an anti-SCL70 positive, an anti-centromere antibody positive. This confers a higher cumulative risk for severe interstitial lung disease and pulmonary hypertension. So remember this combination. Second, the presence of significant pulmonary vascular disease should be strongly suspected when pulmonary function tests shows a lower diffusion capacity and a disproportion which is disproportionately lower as compared to the FVC. So this is similar to combined pulmonary fibrosis emphysema, which also has a relatively preserved FVC and a very low DLCO. The cause, however, in this case is the presence of pulmonary hypertension, the vasculopathy in scleroderma that I spoke about. Third and most important, the management of severe scleroderma related cardiopulmonary disease requires a comprehensive strategy. There's immunosuppression for inflammation, there's antifibrotic therapy for fibrosis, and something that was not prescribed till the stage when I presented the case in this lady, the vasodilators, targeted therapy for pulmonary hypertension. So the balance is decided about which feature is the most prominent, whether it's inflammation most prominent, whether it's fibrosis most prominent, or whether it's the pulmonary vasculature involvement, the pulmonary hypertension, which is the most important in these individuals. I hope you found that case useful. The carry home messages hopefully will result in some change in your clinical practice and the way you think about scleroderma. Thank you very much for listening.